Good afternoon, everybody. This is Catherine Topper from Ardent Health Services, and we're going to start the presentation in just a moment. All right, here we go. Again, I'm Catherine Topper from Ardent Health Services. I'll be the moderator for today's HFMA webinar. I do have a few announcements before we get started. Just so you all know, the slides and handouts for this presentation are down in the chat box if you do need them. A couple of upcoming events for HFMA. Registration will begin shortly for our next webinar entitled Patient Financing, Practical Guidance to Comply with the Consumer Protection Laws and Enhance Outreach to Patients with Helpful Payment Options. That's going to be on April 12th. Visit tnhfma.org/webinars for more information on that. Also, registration is still open for the Dixie 2016 Harmony in Healthcare. This conference is designated to support HFMA's commitment to providing programs that enhance the growth and development of its members. This annual conference brings together HFMA members from 5 different states, including Alabama, Florida, Georgia, South Carolina, and Tennessee. The conference will be held March 20th through the 23rd in Nashville, Tennessee. Please visit hfmadixie.org/2016 for more information. Also, registration is still open for the payer summits that are being held tomorrow, March 9th in Knoxville, and March 10th in Nashville, Tennessee. Each payer will discuss current issues and trends with their respective programs, as well as upcoming changes and initiatives. Topics include post-ICD-10 update, bundled payments, appeals, updates for 2016, and other things. Visit tnhfma.org/payer summit for more information on that. Also, please save the date for our Spring Institute, which is May 16th to the 18th, being held in Franklin, Tennessee. More information is coming soon on that event. Just a couple of housekeeping items. For requirements to obtain the CPE certification, you must be connected to this program for at least 90% of the duration. And also, you must respond to at least 2/3 of the polling questions. All right, we're ready to begin. I'm happy to introduce Mario Ferrier. He has over 17 years of experience exclusively in healthcare industry, including finance and operations. He has a deep understanding of third-party reimbursement issues and extensive experience in revenue recovery. Additionally, he has provided process improvement services surrounding labor and non-labor areas within hospital organizations. Mario also implemented expected reimbursement systems and identified payment discrepancies, as well as modeled complex managed care contracts. Mario earned his Master's of Science in Healthcare Administration from St. Joseph's University in Philadelphia. He also earned his Bachelor of Science at King's College in Wilkes-Barre, Pennsylvania. Mario is also a member of the Florida chapter of Healthcare Financial Management Association. Mario, are you there?
I am. Thank you, Catherine, for the introduction. Appreciate it.
Thank you.
Can everyone hear me okay? Hopefully, if there are any issues, you can make a notation on the screen. But the purpose of today's webinar is to identify and get a deeper understanding of Medicare Advantage Shadow Billing reimbursement, and the associated shadow billing challenges and issues that come with that area. And hence the title, Don't Lose Focus, around shadow billing. And we'll get into a couple of areas as to why it's important to understand this. We're going to try to meet those objectives by going through some of the background about Medicare Advantage, describe a little bit of the industry landscape, which is ever-changing. We're going to talk about the rules and the requirements associated with this, talk a little bit about what shadow billing is. We'll go into some of the reimbursements, talk about how hospitals are paid, and then get into the challenges and best practices. Just as an overview of why I'll be presenting this and the qualifications associated with this, I am with IMA Consulting. I am a director here within our revenue recovery practice. But IMA is a national healthcare consulting firm where we provide consultative services to provider-only healthcare facilities. We work with large for-profit and not-for-profit systems from community hospitals all the way to academic medical centers. Our primary focus revolves around revenue management, expense management, and interim management, and then all of the associated sub-service lines. And as I mentioned, revenue recovery and enhancement is an area, and specifically related to shadow billing. Of note, we've been recognized as one of the best places to work by Modern Healthcare several years running. So with that, just to give you some background about IMA. So what is Medicare Advantage? Again, not knowing who's on the phone, we'll really keep this at a high level. But one of the most striking things that I learned really getting into the nitty-gritty of Medicare Advantage is that this is a type of product that's been around since the 1970s. And really I was flabbergasted to learn that, and most folks are not aware that this has been around for quite some time. But really became popular with the Balanced Budget Act of 1997, and furthermore through the Medicare Modernization Act of 2003. And really, what is Medicare Advantage? So as most of us are familiar with traditional Medicare, which has both the inpatient and outpatient coverage for eligible beneficiaries, Medicare Advantage is essentially a spin-off that where commercial payers are able to essentially manage the care of a Medicare beneficiary. And as such, they're enrolled in a commercial plan at the county levels. So what's unique about Medicare Advantage plans? They must offer both a Medicare Part A and Part B service. They limit the out-of-pocket expenses for the beneficiaries. Most of us that are in this environment refer to it as Part C or MA. Most folks get confused between Medicare Advantage versus Medicaid. But for our purposes, we're going to refer to it as Medicare Advantage or MA. And really, why are folks even interested in Medicare Advantage products? Typically, there are enriched benefits associated with those types of products. The use of the plan is somewhat easier to deal with, and there are enhancements such as hearing, dental, and vision that are not typically covered by other avenues. I want to talk to you a little bit about the industry landscape, and this is a chart outlining really the progression of Medicare Advantage enrollment from 1999 through 2015, and these were the most recent stats available through the Kaiser Foundation analysis. You can see how the trend is moving upward, and that's an indication that more beneficiaries are enrolling in these products because they're finding that they have greater access to services that are typically not available by traditional Medicare. So again, when you look at it, back in 2002 and 2003, you see a little bit of a dip, and most of us can recall that Medicare introduced the Part D prescription services coverages, in which case people probably fell out of this and went over to that, but then you could see how it ramped back up dramatically in the upcoming years. So if anything, this chart is really meant to tell you that Medicare Advantage is growing. It's a very popular product. You can see that there's 31% of eligible Medicare beneficiaries enrolled in this type of product as of 2015. The next, again, is all referenced from the Kaiser Foundation, but it's basically a good chart to show you how deep Medicare Advantage has penetrated state by state. So overall, the national average is 31%, and that's fairly significant. And then you can see the state of Tennessee has a 34% enrollment. Basically, it's identifying that of Medicare eligible beneficiaries, 34% of Tennesseans are enrolled in some form or fashion of a Medicare Advantage product. So as you drill down into the numbers again, Medicare Advantage, how it's penetrated in Tennessee. Basically, we have the total Medicare eligible beneficiaries, a little over 1 million. And then you can see the breakout of how many are enrolled in a Medicare Advantage product, a little over 367,000. And then the two counties listed there are showing you where the greatest penetration is in Sullivan County, and then Lake County is showing you the least penetration. So much like you and I probably are familiar with commercial payers for our own healthcare benefits, Medicare Advantage plans operate in very similar fashions. These are operated and controlled by commercial health plans, and so a lot of the similar product offerings are offered to Medicare Advantage beneficiaries. So the first two that we're going to discuss here are things that have been in existence for quite some time, and you have a typical HMO product where it is a controlled network by the plan, where the beneficiary must select a primary care physician, and the usage of referrals is common practice in these types of environments, much like what we see, as I mentioned, in our own plans. The other interesting fact here is that some plans will allow for out-of-network services for higher costs, and again, we'll roll into kind of this PPO model now too, where again it's an established network where the beneficiary has a lot more flexibility, where they don't need to select a primary care physician or require the use of referrals. So these are two of the four types of plans that we're going to talk about. And then also less common are the Medicare private fee-for-service, which again is established by a plan network where the plan decides how much the beneficiary is going to pay for services. Very, very, very not popular as a plan. The out-of-network providers can decide whether or not to treat a Medicare Advantage beneficiary within these plan products, and the beneficiary needs to make sure essentially that the provider would agree to treat them and be covered by the predisposed contract for the private fee-for-service. And then there's also, lastly, the regional preferred provider organizations. And this is really intended for areas that are in a rural setting. They operate very similar to a traditional PPO. So those are the four most common types of Medicare Advantage plans that are available to the Medicare beneficiaries. The next slide is basically showing you, again, a breakout of what the national plans are broken out, as well as what the Advantage enrollments are for Tennesseans. And as you can see, the HMO products are, again, by far the most popular, followed by the PPO products, in which case Tennessee is higher in both categories in there. Fee-for-service, as I mentioned, very unpopular. In fact, they're pushing to have those go away. And again, depending on geography, you can tell where the RPPOs are. The other category has some makeups of cost plans. Again, very specific to area within the country. Demonstration plans, which are basically established to set and test any kind of improvements associated with Medicare Advantage. And then special needs plans where there might be specific diseases or needs that are in existence for these beneficiaries. And again, I'll just go back to the PFS plans that CMS is looking on putting on restrictions and basically doing away with those. So a little pie chart here showing you what the national trend of distribution is once you get into the actual Medicare Advantage beneficiaries, showing you what kind of plans they are enrolled in. Again, HMO and PPO are leading the charge here. And this is a breakout of the 34% of Tennessee's Medicare Advantage beneficiaries and where they fall into the category. So again, HMOs and PPOs are leading the charge based on the ease of use of the plans as well as the enrichment of those plans. This pie chart here is a breakout of the top payers within the state of Tennessee. And as you can see, Keratin is leading the charge, followed by HealthSpring and Blue Cross and Blue Shield. So most of you that are in the on the provider side, back office, front office, probably recognize that this is the greater of the penetrations of these types of plans. So Catherine, if it's okay, I think this is a good spot to have the first polling question happen.
Yes. The first polling question is, what are the main types of Medicare Advantage plans offered by private health insurance companies? You have local health maintenance organization plans, local preferred provider organization plan, Medicare private fee-for-service plan, regional preferred provider organization plan, or all of the above. Remember, you need 2/3 of these questions to get CPE credit, and you do not get dinged for a wrong answer. So I think we have 77% all the above. Waiting on a couple more to vote. Okay. Couple more seconds. All right. The majority picked all of the above. Is that the right answer?
That is the correct answer, yes. Good job.
All right.
Okay. So moving forward, the prior description was really talking high level Medicare Advantage, and really now focusing in on Medicare Advantage and shadow billing and the requirements associated with that. So in essence, Medicare Advantage has blossomed as we've seen, and the associated cost when it comes to medical education really was not being recognized. That is until the Balanced Budget Act of 1997. And as such, the focus needed to be on Medicare Advantage shadow billing and the associated medical education costs that went into this, because historically and traditionally, the IME and the GME payment was built into traditional Medicare, where now we needed a mechanism to capture that for the Medicare Advantage plans as well. I mentioned a couple of terms, IME or indirect medical education, GME or the graduate medical education are two components that are really the focus of shadow billing for teaching hospitals. And for those that have been in industry for quite some time, if you go back to many, many moons ago, the Medicare Advantage plans were in fact required to submit the shadow claim to Medicare. And obviously, you know, the squeakiest wheel in the room sometimes wins out in a battle, and ultimately the plans transition the responsibility over to the providers. And so really the focus is that how do we essentially get additional reimbursement for both the indirect and direct medical education associated with Part C Medicare Advantage beneficiaries. So the next slide here is basically a progression of guidance and transmittals issued by Medicare on shadow billing, starting with the Balanced Budget Act, where teaching hospitals were required to submit shadow claims. A couple unique things that I want to point out too is that up until that point, it was mainly for the acute setting. Future transmittals, it required the subunits such as psych and rehab to submit shadow claims. And then this concept of shadow billing or no pay claims was introduced for non-teaching facilities. And as many as you probably are aware, back in 2010, there was a big to-do for non-teaching hospitals where Medicare determined that they were not submitting the shadow bills or the no pay claims because obviously the SSI calculation was incorrect. And they allowed an open period for non-teaching providers to basically pay catch-up for federal fiscal year 8 and 9 and submit these no pay claims. And then lastly, the introduction of EHR, electronic health records, and the associated incentive program through meaningful use provided additional reimbursement both for teaching and non-teaching facilities. So again, what is shadow billing? Most of us refer to it as information only or no pay claims. Some of us refer to it as IME claims. You know, depending on what type of provider organization you are discussing this with, teaching hospitals have a vested interest, primarily from an IME and GME reimbursement standpoint, in which case they refer to it as an IME or shadow claim. And then on the non-teaching side, the providers typically refer to them as information only or no pay claims. So again, what is the purpose of this? Well, Medicare again wants to ensure that they are providing the additional reimbursement for the associated medical education of this, as well as collect the days that are going into a variety of different reimbursement calculations. So what you're seeing here is a typical hospital admission for Medicare Advantage beneficiaries. And ultimately, the patient is admitted, they have their episode of care, they're either discharged or transferred, and then as we get into the actual nuts and bolts of the revenue cycle, there are essentially two claims that are submitted. The first, obviously, is to the Medicare Advantage plan, and then the second one is directly to Medicare, or the shadow claim. And again, these claims are essentially identical, with the exception that for the Medicare portion of it, the payer change, as well as some condition codes. And depending on the type of organization you are, you're either including a 4 and a 69 or simply a 4. Catherine, I think this is another good point to ask the second polling question.
Okay. In what year was the requirement to shadow bill for IME and GME payments placed on teaching facilities? Select one of the following: 2003, 2010, 2007, 1997, or 2011. Give it just a few more seconds for a couple more people to vote. All right, let's see what we have. Looks like we have a few different ideas. 32% for 2003, 16 for 2010, 5% for 2007, 37 for 1997, and 11 for 2011. What's the right answer?
Okay. Well, the correct answer is the requirement for teaching hospitals started in 1997.
All right.
Okay. So, getting into the shadow billing reimbursement, why are we shadow billing? I briefly mentioned the purposes are to essentially receive additional reimbursement for indirect medical education, graduate medical education, and most recently, meaningful use dollars incentive programs. And then also compliance. This is, contrary to popular belief, not a choice. It's a requirement. And again, teaching hospitals have been on the forefront doing this because there is obviously a reimbursement implication. And then, non-teaching hospitals have some sort of reimbursement implication as well as of recent years due to meaningful use. The most striking thing that's been mentioned through all the regulatory guidance and correspondence has been that if providers are not in fact shadow billing, they could threaten and wave a stick and take away DISH payments for those providers that are DISH recipients. So when you think about this, this is really focused around the 2010 era for non-teaching hospitals to get their no-pay claims in. As of today, that has not happened. So it's really kind of walking on that thin ice, so to speak, where the threat is out there to do this, but it hasn't occurred to date. Not to mention that the open period for non-teaching providers to potentially submit back no-pay claims is potentially out there as well, much like they did in 2010. So, indirect medical education. When we talk about that, kind of get you the payment mechanisms that are commonplace for this, and seeing how an eligible hospital gets paid for this. Basically, the purpose is that it's covering any kind of indirect cost for a teaching facility for their interns and residents. So basically, when you have a teaching program, there's the high cost for treating patients in a teaching organization. And residents will typically order more tests than a more experienced physician. And so they want to make sure that there's some cost coverage there. And then the way this occurs, it's based on a med student to bed ratio. So every facility, every teaching program has a different IME payment. So the folks that are involved in the patient accounting aspect of this, when a shadow bill is submitted and it's a clean shadow claim, it will process much like a traditional Medicare claim, in which case a clean claim typically adjudicates within 14 days of submission. And the way that we recommend and the folks that are involved in reimbursement to track this, much like all of your other Medicare activity, you'll see the accounting of this on your detailed PSNR, which is your statistical and reimbursement data report. So the payments by account, by patient are listed there. I know a lot of folks on reimbursement side deal with the summary PSNRs, but the details where you can actually drill down to the specifics of this. The other thing that I've mentioned is the graduate medical education. And again, it covers the direct cost for the teaching program. So when you have residents and any of their associated costs and training, you have the salaries and fringe benefits, the supervision of these residents, as well as any kind of overhead costs, whether it's electricity or maintenance, etc. Again, the GME payment is really reflective of the days that are associated with that episode of care. And these types of payments occur not real time, but rather they occur at the time of cost report as a pass-through payment. So really it's important, again, knowing the detailed PSNR to ensure that the claim has processed all the way through and adjudicated in order for, one, the IME payment to come within 2 weeks, and then the GME payment to come through at the time of cost report. The last mode of reimbursement is the incentive program for meaningful use. And for most providers, eligible providers, they are in the heat of this as we speak. The program started in 2011, and basically it was to incentivize providers to implement a electronic medical record. In addition to the $2 million base that providers were receiving for implementation, the incremental portion of this was identified through a calculation for the additional Medicare Part C days. So again, this added additional monies to teaching hospitals as well as non-teaching hospitals, which historically had not been receiving payments for shadow claims. So it really added a nice little uptick in revenue. And much as the title of this is not losing focus around shadow billing, now more than ever for this year, this is the last year of the incentive payments to be coming through. And so it's really important to ensure that your shadow bills and no-pay claims are going out the door because there is still the opportunity for additional reimbursement. And again, most providers right now are in stage 2 of the meaningful use aspect, so they're the advanced clinical processes. And again, the program goes through stage 3, and that will be through year 2018. So some additional reasons to shadow bill I mentioned before is the implication for DISH calculation. So I know the argument stands that the more you shadow bill, the less your DISH payment is going to be, which may be the case. And the response to that typically is that shadow billing is a requirement and as such needs to be done. So at the end of the day, when you look at your DISH payment versus your shadow billing payment, it should wash itself out, especially on the teaching side. Nursing and allied health also has an impact for reimbursement. This is again done several years after the year's cost report has been filed and is distributed through a pool of monies that are available. Again, the days that go into this calculation are utilized for Part C. And as I mentioned, compliance. It's not an option not to shadow bill. It is a requirement, and as such, the threat of taking away a DISH payment is still out there. I'm not sure how relevant it is, but it still exists, and based on all of the regulatory guidance, you are required to shadow bill as an acute care provider. Catherine, I'm going to ask that the last polling question be asked at this time, and then we're going to go through the remainder of the presentation.
All right. The third question is, what is the purpose of shadow billing? To receive supplement IME payments, to receive supplemental GME payments, to receive supplement EHR meaningful use payments, Medicare cost report accuracy and compliance, or all of the above? I'm going to give it just a couple more seconds to get a couple more people to vote. Okay. And it looks like the majority, 95%, chose all of the above.
And that is the correct answer.
All right.
Okay. So this is the last portion of the presentation, and really focusing in on the challenges associated with shadow billing. Some of you might be thinking that, wow, this is pretty straightforward, and this is occurring, on a daily basis, which I would agree with you. But with most things, there are challenges that are associated with it. To my colleagues that are in the back office, I'm sure once I go through these, you could definitely relate to why shadow billing may not occur and occur correctly. But the back office of any provider organization has its own challenges. They live it, they breathe it, day in and day out, and ultimately, there's increased pressures to recoup any additional monies that are owed to a provider, and then there are compliance issues that are hovering around that environment as well. And basically, when you look at shadow billing, it's basically another step for that same patient. So another claim has to be created. And if it's not hard enough to have a clean claim from one side, having another claim to worry about and think about only adds problems to it as well. So this is a niche part of the revenue cycle. Most organizations assume that this is being done, and depending on their risk tolerance, will allow certain errors to occur, working higher dollar claims versus lower dollar claims, which shadow bills are, comparatively speaking. So the attention that this gets may not necessarily be as high as other areas within the revenue cycle. But the challenges associated with even getting a claim out the door, when you think of a Medicare Advantage beneficiary coming to you and registering for an inpatient stay, they're carrying around their commercial insurance card. So at the time of registration, certain information may not be collected, such as the HIC number, which is required on the Medicare portion of the shadow claim. And as such, the claim can't go out the door, can't process correctly. So being able to capture that information is very, very difficult. Once you do have that and the claim does go out, you're submitting the claim to the MAC. And the same plethora of reasons why a claim could RTP can occur for a shadow claim. So whether or not that claim is being worked from a priority standpoint bodes to be the question. And obviously on the non-teaching side, where you have zero payment for this, it's very unlikely that the claims are ever being worked. So again, focusing in on some of these areas can really shed light. So being able to collect the information up front, ensuring that on the back end claims are being worked, if there's RTPs or any kind of rejections. And also knowing some ins and outs of shadow billing, whether it's combined stay or readmission, being sure that you're able to maximize and capture, maybe not so much from an IME standpoint, but from a GME standpoint where there are additional days for that longer stay. So be aware of that. As I mentioned, shadow billing may not be a priority for non-teaching facilities. There's no IME and GME. This year is the last year for meaningful use payments, so there should be some, excuse me, some focus around that. Areas of opportunity that we've seen are in the realms of system conversions. When you think about the planning, the testing, and the implementation that goes on from a system conversion or implementation standpoint, there's a tremendous strain on resources. Where are the priorities within the organization? And being able to circle back to whether or not the system was set up correctly for the purposes of shadow billing, to ultimately, if this is a sideline process where one person or two people are responsible for it in the back office, are they stretched too thin? The beauty of shadow billing, or depending on how you look at it, is that it's very unforgiving from a timely filing standpoint. So if you don't submit the claim within the timely filing guidelines, which is a year from discharge, the claim will not be accumulated on the PSNR. You will not receive IME payments. You will not receive GME payments. And the associated days that would typically go in there are not captured or counted. So some best practices. I think we'll go into with really like how can we ensure that shadow billing stays on the forefront of an organization's revenue cycle and ensure that things are being done to the best of their abilities. First off is really understanding and reconciling to the detailed PSNR, and that's typically the 118 report for the Part C beneficiaries. Really understanding what's going on there ensuring that the MAC is capturing it. Oftentimes, when we look at things, the MAC has no record of it yet. The provider has demonstrated that the claim has gone out successfully, and they have not received any kind of rejections or return to providers for any unsolicited reasons. So the MAC typically would have an issue on their end. So being able to understand and reconciling to the detailed PSNR is very important. Being able to review the shadow billing process, whether that's internally or externally by conducting ongoing reviews. As I mentioned, timely filing is not negotiable, and as such, if you plan on getting to that project, time is not your friend in this case. But really being able to do either an internal audit to make sure that the claims are going through as expected is very critical. Communication, and that's both on the internal side as well as external. Internally, new payers are coming into the mix, making sure that your systems are speaking correctly, making sure that the products are identified as Medicare Advantage products is critical. From the patient accounting side to the reimbursement side, definitely staying in communication to make sure that the days are being captured. Oftentimes, in the background, reimbursement folks are accumulating the days for those patients. However, the shadow claim may not be going out the door, and again, timely filing creeps up. Externally, talking to your peers. What are you seeing, especially if it's in a similar community where the MACs may be messing things up, which they've been known to do. So really knowing what's going on amongst your peers is a good way to stay in touch on this topic. And then lastly, being creative. There are a lot of intricacies even in this niche area known as shadow billing. So knowing if you are registering a patient correctly and ultimately if that patient would assumably become misclassified and ultimately a shadow claim may not go out the door. So knowing that, and then looking at some non-traditional areas. So we always focus in on Medicare Advantage beneficiaries being over the age of 65, but there's a whole subpopulation of under 65 Medicare Advantage beneficiaries where they could be being missed. So another area to look at. So with that, a couple of takeaways, not losing sight, related to shadow billing, Medicare Advantage shadow billing. Medicare Advantage is on the rise, so from a volume standpoint, there will be additional shadow claims that are going out the door. Despite meaningful use going away this year, it's still critical to submit these shadow claims for, again, the historical reimbursement modes for IME and GME. And unfortunately for non-teaching providers, there won't be any additional reimbursement. However, the compliance aspect of it still exists. And to give you some perspective around this, based on our experience, most organizations are missing anywhere between 5 and 10% of their shadow bills, meaning that either they haven't shadow billed them or they never worked them through an RTP or rejection work queue. So again, don't think it's being done without really delving into some sort of analysis and review, because we're seeing that 5 to 10% are not actually occurring. So with that, I'll open this up to any questions that might be available.
We do have a few questions coming in. A question from Michael. Do surgeons and hospital-based services such as radiology and anesthesia shadow bill? And does it matter if they are hospital employed or independent?
Thanks for your question, Michael. Medicare Advantage shadow billing is occurring at the acute level. Individual radiologists, anesthesiologists are not required to shadow bill. So there is no impact for the Part B, the traditional Part B providers. This is only relevant for the acute setting, including their subunits such as psych and rehab.
And I think that's the only question that we have so far.
Okay. Well, my contact information is on the last slide, which I believe is going to be available through your website. If there are any additional questions that may arise after the fact, feel free to call me or email me, and I will be glad to answer them.
All right.
Hey, Catherine, this is Martha Calfee. One thing I noticed there's seems to be a problem with our link to the handout material. So I just wanted all the attendees to know that we are working on this. I'm not sure what has happened with that link, but we will get that up, if not this week. Just keep checking back on the TNHFMA.org under the webinar section, and we'll have that up shortly.
Yes. I was looking into that, and I don't see the slide, so thank you for addressing that, Martha.
Thank you.
If there's nothing else, then this will conclude our presentation for today. Thanks, everyone.